Okay, we're going to get started here. So it's a great pleasure to introduce Dr. Farouc Jaffer, who is the Medical Director of Mass General Hospital CAD program and also the co-director of the Chronic Total Percutaneous Coronary Intervention program at MGH. And he's also an Associate Professor of Medicine at MGH, Department of Medicine, Cardiology. So I think most of us who have joined in, I think know very well Dr. Jaffer and his accomplished CTO program, and I think we are looking forward to an interesting array of cases from his lab. Farouc, can you give us like a brief synopsis of what this is going to be, and would you prefer if we comment in the middle, or you would like to take questions at the very end?
So thanks so much, Subhash. It's absolutely a pleasure to be part of this very exciting webinar. I have learned a lot myself from watching the prior ones, and it's an honor to be invited and to join together. I am completely open to questions at any time, and certainly appreciate all of your commentary. I'd like to keep it open and interactive. I think all of us will get more out of it that way. And I have several cases looking at a range of issues that we might face during a variety of CTO interventions, and would be delighted to have your expertise and the audience participation as well.
Absolutely. I also invite the audience, as Farouc queues up his case, to feel free to interject, as both of us would be very open to entertaining any questions during the presentation. So Farouc, take it away, please.
Okay, fantastic. So we'll jump right in there, and this is the first patient. These are my disclosures related to research grants and consulting. And this person was a young guy, 51-year-old. We'll start with 3 cases, but briefly, new exertional angina that presented in the last several years, previously with only exercise, but then about 8 months prior to admission, it began to progress, radiating to his throat and upper shoulders with walking, and he became kind of class 2 instead of really class 1. He underwent exercise stress testing, had a intermediate to high-risk stress test, as seen by 2 to 3 millimeters of ST depression, a moderately large anteroseptal, interseptal, and infraapical perfusion defect. He had a diagnostic catheterization at an outside hospital, which we will go through, and showed that he was left dominant, had a mid-LAD total occlusion, and a severe distal circumflex stenosis. He had a normal ejection fraction, small area of wall motion abnormality. He did not have diabetes. He was a full DAPT candidate and had no other high-risk medical factors. So from an AUC standpoint, he was definitely in the either indeterminate or acceptable range, depending on his severity of a stress test, and that's important to us. I imagine that's something that you guys look at routinely prior to taking people. Is that right, Subhash?
Absolutely.
Yeah.
Absolutely. I think that's a good point.
Great. And so his medications here, he showed he had presented on 2 anti-anginals, metoprolol and amlodipine. He was becoming blood pressure limited with further titration. So again, with most of my patients, I really do try to maximize them on optimal medical therapy, even though sometimes they're referred for a CTO directly. If I feel like their risk is going to be higher clinically, we will titrate medications jointly with our referring cardiologist. And we have basically made some people minimally symptomatic and avoided the risk of procedures. In large cases, that does not work, but I think it's useful to weigh risk-benefit for every patient. And some patients can become quite comfortable with addition or up-titration of a second or third anti-anginal. For him, he was at the maximum of what he could tolerate from both the blood pressure, and he also had a headache issue with isosorbide. His exam was benign. EKG was relatively benign. Here's his diagnostic catheterization. And what you can see here, is my pointer coming through as well?
Yep. Yep.
Okay, great. One can see here that there's really an absence of an LAD vessel that eventually fills left to left retrograde, and he's left dominant, and there's really 2 sources, both diagonal and LPDA, filling part of this distal LAD. The most noticeable thing is that there is a moderate severe stenosis here in the diagonal, as well as the inability to really resolve the entrance to the proximal cap, which is probably coming off in this zone in this view, but the actual true beak here is hard to anticipate and really understand how to probe in these situations. Another view of this here in a more AP cranial, LAO cranial view. Again, good target vessel all the way down. Doesn't appear to be a large degree of stenosis distally or diffuse disease. He's relatively young, and so that's fortunate, and he's non-diabetic. So he has had an opportunity to not form so much plaque. This looks like a good target vessel suitable for coronary intervention. He also has a severe stenosis down here in the, sorry, go ahead.
No, I'm saying exactly. You see a little bit of a indentation, but you're absolutely right that you can be sure where to probe here.
Right. And there is a severe distal LPDA lesion. So he did have significant two-vessel disease with a mid-LAD total occlusion, a diagonal here that would count towards syntax, as well as a distal LPDA. His syntax score was still in the low tertile, and given his lack of diabetes and normal EF, we thought that offering coronary intervention percutaneously would be reasonable here.
Agreed.
Do you and maybe the audience can jump in as well, but is a syntax score kind of routinely calculated for folks in the audience in making these decisions? Is that important?
I think at our lab, I think we kind of require it and discuss it with our fellows. So I think, yes, it is helpful. And I think that it also provides a common reference point in terms of strategies of revascularization. So I agree that in this particular case, despite the low to intermediate the syntax score, I think it would be reasonable to, this is a reasonable PCI case, especially in a non-diabetes patient.
Agreed. Right coronary here, severe lesion here in a non-dominant right. There are collaterals from a conus branch here that come over the top, but did not look to be an interventional type of collateral.
Agreed.
And so looking at this here, it might be reasonable to pause about how to really approach this LAD. And I've put some suggestions here. So here's the summary. Left dominant, LAD 100% mid-total occlusion after a large D1 that had ultimately we graded it at 40 to 50%. The second septal was collateralized from OM2. OM2 itself had a 60% lesion, the LPDA had an 80% lesion, and the non-dominant RCA had an 85% mid-stenosis. His LVDP after angiography was slightly elevated, no valve gradient. He was initially medically managed, and then eventually, because he became limited, sought out a CTO PCI program.
So Farouc, the only comment I would make that despite the fact that there was left-to-left filling, I think it's evident, I'm sure more on your side than on the webcast, that the distal LED does not opacify in a very continuous fashion, and that might be because of the competitive flow from the conus branch.
Quite possible. Certainly higher up in the mid-LAD area, for sure. I think we get some filling at the distal part, but yes, there is definitely competition there that limits our visualization. Agreed. And even looking at the, while we did not have full dedicated non-pan views for our REO cranial, the robustness of the collaterals from the septals, what is your sense of that, looking at the LPDA, for example? Is that a retrograde option in your mind?
Not in my mind. I think here trying to, at least in my opinion, again I invite all to jump in. I think trying to figure out where the cap is, with IVIS or other means, and IVIS probably is the best way to do it, and then try to do a antegrade approach. Probably would be my first choice here, and not try to probe the collaterals at this point.
Okay. Yes, they are very faint indeed, and that was definitely one of our concerns. This is always a challenge with ambiguous proximal caps. If one has a nice retrograde option, sometimes that's a great way to resolve the ambiguity. But one can see here really a very faint arcade is certainly nothing that is looking highly robust and straightforward. So I think our opinion was that also an antegrade approach might be possible. And so with the antegrade approaches, There's really a range of different approaches, for example, to discuss, and some include cap manipulation, such as you have written about with Monos, really moving the proximal cap. Looking at this, for example, lesion here, do you feel that either base or scratch and go is a advisable option? Would that be a way to start this, or would this be a case where one just wires?
No, I think given the fact that there is a very large diagonal branch right next to it, I think that it might be better to find and locate the best possible point to interrogate with after doing IVUS. I think that's probably the best way to approach this one.
Okay, great. We're in agreement about that. We felt that IVUS-based guidance could be quite helpful to really resolve the answers to the proximal cap, because while looks like there might be fill-in here,
yes,
right there might be a beak. Sorry, it might be a beak. It's hard. It can't pop this out very easily. Yeah, it might be a beak in this area here. It's still not fully resolved about where that's going to go, and one obviously does not want to harm the diagonal entrance. We were certainly going to place a wire there to protect it and understand if we needed to treat it at the end. But the actual entrance it's harder, and so I also agree with the presence of that diagonal. Maneuvers such as base or scratch and go would potentially compromise that diagonal. What do you think about open sesame in this situation? Has that worked for you?
Well, that's a difficult question, but I think I want to see a few more views of this. But tell us, what do you do here next, going forward?
So I think that we've agreed that using IVUS was going to be helpful. But one of the first things we did is we wanted to take a better picture, and we actually so when we started this intervention, after deciding he was suitable to proceed, we chose an 8 French system, a single guide with an AEBU, I think it was a 375, into the left coronary. And then because we were getting some concern of really crosstalk from the circumflex system in collaterals, we decided to selectively inject with a 6 French guide liner.
I think that is the best decision. This is probably one of the important, simple thing to do, but very, very helpful in these ambiguous situations.
It's almost in some ways like a mini Carlino, but really just with good angiography. And you can see here now this total occlusion is more visualized. It's still not entirely clear where the true entrance is, but the actual CTO looks very short now, 2 to 3 millimeters. And so,
I think for those who are joining in, Farouc, can you describe the mini Carlino? I just want to make sure that everybody is following us.
Yes, sometimes in a situation where there is no clear entrance into this ambiguous cap, if we get close to a side branch and we were to actually inject either at a moderate level or forcefully through a microcatheter placed right at the side branch where we think the main branch proximal cap is, by injecting contrast in a selective way, sometimes we can increase the hydraulic pressure enough to open up a channel that illuminates the true proximal cap and allows us to actually get in there with devices, either wires or for knuckles. And while this was not done for that intention, it was really just to define the entrance. The concept would be the same if we had placed a microcatheter closer to that distal cap or proximal cap and injected more forcefully.
Have you done it? Have you done it? I have actually personally not done it for an ambiguous cap, but have you?
I have done it actually quite recently in a very retroflex circumflex where it was very, very hard to make the turn, and I had to distort the geometry, and that actually ended up creating a star channel that caused recanalization. And we could not wire the star channel. They're not easy to wire, those connections. And curiously, it actually resolved his angina despite our lack of ability to stent it. He got enough flow just from that. So a Carlino in a bailout environment, it can be really wonderful to modify that proximal cap. So I think it's a super handy technique. In this situation, I think we probably would have created a subintimal plane based on the fact that we couldn't precisely land the microcatheter just to the true entrance of the lumen. It would probably be off axis and cause some trauma. So our thought was I think the two choices here now, and maybe you could tell me your approach. Do you think we should start off with straight wires and try to manipulate it, and what wire might be the best one? And then alternative, should we think about using IVUS here to try to actively wire?
I think IVUS probably is, again, the best way to do it. I'm curious to see how did you, if you will be able to show IVUS images. I think wiring with concomitant IVUS imaging probably is my preferred way in this particular situation.
Okay, great. We agreed, and I thought, I may have just one or two chances to really enter that lumen in the true proximal cap to really wire it true to true, which in some ways is kind of optimal, of course, to avoid an unnecessary antegrade dissection reentry approach. While I think it would be successful, it's definitely not as simple as a direct wire. So we agreed, and we moved towards this. We were discussing about some of these options, which include options for an ambiguous proximal cap, which is to move the cap approximately not really appropriate for a case where we have a large side branch that would be compromised. Open sesame, where we could dilate. And again, I've seen some cases of this. I haven't had a personal experience where it's worked for me yet, but it seems plausible that this might be a way that we get enough of the balloon to modify the proximal cap. IVUS guided entry. There is some work going on with real-time CT angiography, both offline and actually during real-time fusion CT, where one might be able to look at the angle of the LAD and understand where to probe a wire based on the CT angle between the main branch and the side branch. So that might be some ways to do that. And then the Carlino approach, and then, of course, considering to go retrograde if there are suitable collaterals are certainly is a great way to resolve the ambiguity. So moving forward with IVUS here, this was our pullback through the IVUS, and you can see here at 12 o'clock now, this large structure here, as we pull back, that is making direct contact here with the side branch. The IVUS, this is an eagle eye catheter, short tip, placed into the diagonal side branch, and one can see here now this large circular structure, which is full of material consistent with the LAD. And so, and one can now really mark here where the contact approach really comes in with the diagonal. So I think we get very close here to knowing in this zone right here where the actual LAD is, right and about here. So this might be a good place to consider directing a wire to. Now, sometimes it's not always possible to do this under IVUS, but to really see your wire and direct it. But that was our hope, is that if we brought in a specialized wire, that we might actually be able to probe it, first direct it in this orientation in the IVUS, and then go back to fluoroscopy to see if it actually traverses where we want. Is that typically the way that you might consider doing something?
And a support catheter, did you think of it, or?
Yes, this was. We were going to take a support catheter, and I think we chose a
Corsair or Pinecross. What do you?
We chose a Corsair. We chose a Corsair for this one just because I thought a little spinning might be necessary through that very tight proximal cap. Yeah. But yes, in terms of the approach, I think ideally, if one can see the wire point towards your target vessel on IVUS, then move one's eyes towards X-ray, that it can be a nice way to kind of give you both direction and then movement to try to get this via angiography.
And just one comment, that one of the best places to do this IVUS-guided side branch access is actually the LAD diag bifurcation. Some other vessels can be even more tricky, but because in this situation in the areocranial or apicranial view, you can definitely locate the movement of the tip of the wire and also position it first with IVUS. So this will be a good one, I think.
That's a great point. So this is actually now with the wire here. You can see the wire is now basically from this wire, which we chose was a second wire, and actually it has crossed here in the IVUS plane. You can see that.
So you already started with the Gaia.
We started with the Gaia because I was really interested in having a very fine manipulation control through this to be able to rotate it exactly one-to-one in the IVUS plane. So I know from a hybrid approach we could certainly have started with an XT, and that might have been the case, but I thought if I could get really precise control to direct it towards this angle, that might give me the best chance to really track that microchannel into the proximal cap. I guess asked, would you have chosen an XT in this situation?
I personally would have there are two thoughts. I mean, I think Gaia is a great choice here, and recently we have not only used it in such ambiguous casts, but also in with stick and swap re-entry with Gaia 2 and 3. So, but I think the angulation of the tip of the wire also helps in this particular situation.
Right. Right. So, fortunately, like this actually did find the entrance to the proximal cap here, and you can see as it crosses over, as soon as we start to see the LAD forming here, you can see it looks like it just jumped right into the LAD. So it looked like it was true.
Right.
It felt, when we went to angiography here, this is where we recognized that it did in fact look quite true. It was nice and straight. This wire did not buckle, and one can see here the pre-shaped tip of the guy wire. This is the IVUS catheter, the eagle eye here, and this allowed us to cross what eventually was found to be true to true. As soon as we got past really the first 10 millimeters, we brought the Corsair down where we felt comfortable, and then we took a workhorse wire to really wire the rest of the LED rather than wiring with the guy second and risking a secondary dissection downstream.
Absolutely, absolutely. I think that your point again is that if folks want to use the Fielder XT, it would be completely appropriate in this situation. But I think this is a great demonstration of using the Gaia simply because of the torque control.
Right, it really made a difference. It was really quite apparent that we could select that angle on the IVUS and get there. So now at this point, we exchanged. And I think I actually went with an XT because I wasn't sure how long that lesion was right there, so I probed a little bit more with an XT, and that also felt very straight. And then we ultimately went through with a run-through and got into the distal LAD. And at this point now, it becomes balloon and stenting as usual. We kept the wire down the diagonal, and ultimately ended up placing a 2538. We jailed the diagonal, and we actually thought this lesion itself wasn't significant enough to justify empiric stenting. We finished actually, though, however, with a KISS right there, and I think that was because we did see a significant stenosis about 70 to 80. It was not enough to justify a two-stent approach. We did a kissing POPA, as you saw here, and the final result looked reasonable here with TIMI 3 flow. We ultimately went and fixed the the distal circumflex as well to try to give him complete revascularization since he had evidence of ischemia in the interior posterior wall.
So Farouc, you chose for the LAD a 3.5 stent, or?
Let me see that actually. What did we choose there? Sorry, it was 2.538 distally here. Distally sized at by 2.538, and we did actually IVUS this here before finishing because we were actually post-dilated up to 4.0 proximally. So one can see here in front of the diagonal that this is quite a large vessel. And so that's kind of getting to the limits of the Alpine. I think it really goes to about 3.75. There's not too many stents that go from 2.5 to 4.0 anyway. It's a pretty decent mismatch, but I think in general, non-diabetic and good apposition by IVUS, we were happy with the result.
Sure. Excellent. I think any comments from those joining in the webcast? I think people could definitely ask Farouc or say, it would be not inappropriate to stent the mid-diag. I mean, that might be an option. I think he has great flow in the bifurcation, so I agree. I personally would have used slightly larger stent, but I think the apposition here with IVUS controlled visualizes looks outstanding. So it's a great result and great case, and there's a great demonstration of this. With the open sesame technique, I think is something we've used very rarely. I haven't done many open sesame, but I do think that in situations like this, I think Farouc's slide of outlining all the 5 options of how to deal with an ambiguous gap, and this is a great example. Perfect, fantastic. So, Farouc, one last question: with the distal circumflex, so so the distal circ, you just balloon stented, and I didn't see the final result. If you could show it one more time. I think I got distracted a little bit. Okay, that's it.
This is the final result right here. So the stent was placed right here at long stent 275/28, post-dilated up to 325, and that kind of gave the distal inferior posterior segment good blood supply.
Great. Excellent case. Farouc, let's move on to the next case.
You bet. Let's go to the next one here. And this one is a good case. Looking at a very common situation for us clinically, which are taking care of our post-CABG patients who can routinely present many years later, decades later even, with refractory angina due to vein graft failure. So this gentleman was 79 years old and had his first bypass in 1983 and then a redo bypass in 1990. He had multiple PCIs to vein grafts, including one with intra-aortic balloon pump support in the 2000s. Ultimately, he had recurrent angina and underwent angiography here, and in October of 2013 was found to have only a patent lima, but occlusion of his vein grafts to his right PDA as vein graft to his OM. So the very common scenario of patent lima, severe angina, occluded vein grafts. These cases, in general, by most guidelines, are thought to be Class 2B for redo CABG because of the risk of traumatizing the lima and not having a lima option to really extend mortality. And I am sure, Subhash, you have seen many of these patients are often quite limited, and they're often told they do not have options due to the complexity of their native disease and their vein graft disease. Have you had greater understanding? Do you feel like that your local community and now more nationally are realizing the potential to help these specific patients in the post-CABG setting? Are you having patients continually being referred for redo bypass, or are people now starting to become more willing to send these patients to CTO centers?
Well, as you know, Farouc, at our center, we probably don't get many referred to a second bypass surgery after, especially with a patent lima. I think that this has been for a long time, and we've done quite a few studies specifically interested in bypass surgical patients. So I do think that this is a perfectly appropriate patient, and referring these patients with a patent lima, in my opinion, is probably not the right way to approach this. So I don't think we have a difficult time convincing our referral base that PCI for CTOs for these patients is the way to go.
Agreed, and I think our surgical program has been very, very pleased with our ability to support them because they are actually sometimes directly referred redo bypass patients, and they look at them and they say, with the patent lima, we're extremely hesitant to reopen the chest. And so having these other options and having a center that does CTO PCI in the area has been really helpful for them. So this gentleman, thank you, Subhash. This gentleman was tried for medical management. Initially had moderate ischemia on a MIBI, but ultimately the following year had accelerating angina on 3 antianginals. He was planned for total occlusion intervention, but due to unstable angina, actually the case was expedited, and he drove up from New Jersey in his car for 5 hours and was admitted. He had a tremendous connection to his prior cardiologist who had taken care of him throughout his 30 years. His diagnostic angiogram here shows indeed what we're talking about, which is a patent lima, and you'll see a large collateral here that is a marginal collateral filling part of this early takeoff RPDA system here. You'll see it here on the other side in the LAO view. Again, a large territory overall that eventually it's going to fill here. In the PDA. We don't see it fill entirely proximally, of course, so it's not clear if there's another source of flow here. So we started looking at his native left and looking for septal collaterals. And these in native S1 were not particularly impressive. But we were curious about this, given that he had a lima that did not seem to show a lot of septal collaterals, and he did not have an S1 natively that showed a lot of septal collaterals. Unusual to not have some form of septal collateral filling that would be robust. So it suggested maybe there was another source of collaterals was one of our questions that we had. It would be unusual to fill the entire right coronary from an RV marginal connection that we were seeing. I'm not sure what your thoughts about that are. But
I actually, it is playing. The play is a little jerky. But can you show me again the lima? Is it filling from the lima at all?
Not really that much here. So here's the REO view of the lima.
I see. Left radial
and you can see here this marginal, but not really a lot coming in from the
but
collateral arcade.
You see something is coming down from it, so it is, yes.
Yes, that I think we believe was the marginal actually filling the native right antegrade now from up here.
Yeah, I think so. I also agree with that.
This is an early takeoff RPDA type of situation here,
right.
Coming up high here. We don't see the posterior left ventricular branch filling very well, except a little bit at the very end coming out this way. But it was unusual to have this filled antegrade. Just our usual sense is that we would have septal collaterals that might, yes, from the Lima or native S1. So we needed to also then understand what was going on, of course, with the right proximally, and additional pictures here of the left from the native. Really not very impressive here, very faint.
Yeah, I'm not impressed either. This is surprising.
Right. So final shots here looking maybe for circumflex the posterior left ventricular branch. Maybe we get an epicardial AV groove. Again, not particularly promising, and these are often so tortuous we're not thrilled to use them, but in this case there really is not really anything that's really looking significant there from the native left. So we looked at the right. Here's the graft, and this is occluded, and would be interested to hear your thoughts about whether or not this would be your intended retrograde approach.
Oh, wow.
And now here's the reason why we're not filling. Here's the reason why we're not filling.
Yeah, this is impressive. This is impressive.
So a
wow.
very, very large ipsilateral collateral filling that filling really the whole posterior left ventricular branch system, and you can see part of the RPDA system, which has competitive flow from the RV marginal collaterals here. So a very, very large system dependent on an RV marginal collateral and ipsilateral RCA collateral.
Yeah, this is unique. Do you have a RAO view of this? Because I think this is going to be a fairly complicated. Oh, here you see the RAO. That's great. Great.
Yeah, so exactly as you're requesting here. So RAO, so it does in the LAO view, it looks a little ambiguous. In the AP cranial view here, also a little bit ambiguous. Hard to know if one could just advance a wire into this what looks like this proximal cap here, and this looks like this large ipsilateral RV marginal type collateral coming around. Let me ask, would this be a source of an ipsilateral collateral for you if you had to really do that? What do you feel about this actual RV branch as an ipsilateral collateral?
I mean, I think the RAO view probably is the best one, shows some promise. I would agree, I think personally. But I think the AP caudal views and the LAO cranial views AP and LAO cranial views are very, very difficult to interpret, at least looking from here. But the RAO definitely looks promising to me.
Yes, I think that's it. I think that's a great point. I'm going to show you the LAO again one more time here. When we were starting this, we were definitely concerned about the ambiguity here. Now, I think at this stage, I would try. In fact, up there at the top, we chose not to go antegrade. We chose to go retrograde because we were very concerned that we were going to end up not knowing exactly where to poke. I think in hindsight, if we could have had a way to really direct a catheter and microcatheter. We're also concerned that the microcatheters coming out of this guide, we might have chosen an AL guide maybe helping us look upward. We, of course, did. But it would be quite possible that the majority of the effort would just be here in this marginal and would not be able to wire. So we actually started looking for retrograde options. And looking at this whole case, everything that you've seen, what would be kind of your sense about retrograde? What would be the right approach here for retrograde work?
The only filling which is difficult is from the circumflex, is that right, that you have from the left, which is quite tricky. And I think we need to play the left-sided picture if you have it one more time.
Sure.
The vein graft, I think, would be, sometime we pass a wire in the vein graft to show you the distal target. That is not an option in this particular situation. But I think wiring through the circumflex is one option, but it is extremely difficult, I think, in this particular situation.
I think it was hard for us to feel at the time that we really had a clear connection down here. Maybe there could be something faintly filling, but there is something. There is a little bit of flow that eventually gets into this posterior left ventricular zone. Just really hard to tease out where that is. Perhaps selective microcatheter injections down various branches might help illuminate that. That was one that was possible. We were trying so hard to find a native left coronary connection. That we did some additional work here looking at the areocranial here. We took one and tried to find one in S1.
No.
But we're not able to do that.
I don't see one here.
So very difficult here. Really not, we said, should we spend any time trying to probe this? We just didn't see any connections at all.
No.
And so our thought is, we didn't really have good native options. What do you think about the right coronary bypass graft? Is that a reasonable option? It had been stented.
We have actually, that is probably the safest. You can't really harm it. And we have actually very recently done a case like this where we couldn't figure out how to access it. We did put a wire down and try to get retrograde through the graft. And I think the fact that it's stented probably makes it, at least a head start, you have a clear knob into the stent. I think it might be promising to definitely probe that, because none of the other options are looking really appetizing to me personally here.
Yep. I agree. Our experience with these ones that have been stented is that the tissue has been super rigid and hard to get through. But it is certainly, I agree with you 100%, a very reasonable option to consider first. Every now and then, especially if the occlusion is recent, one can get a pilot 200 to really fly down the graft. The actual connection to the RPDA is always intriguing. I don't know if there's anything that you use. We've been trying to use CT and having our radiologists work with us to really map the angle of the distal hood plug-in to the RPDA to know if the angle... Yeah, they can be modestly helpful. We did not see any backfilling of a vein graft into the RPDA, so it looks like it's a flush occlusion with the RPDA. And if the angle of the graft is sewn in so that you're pointing downward to the distal PDA, it becomes very difficult, very difficult. Sometimes we use CT trying to get us that angle. They're working on trying to get us that particular type of information to help us understand if we do get down there, what are the chances of making a northward left turn to get proximal. So when we looked at that, we were concerned about this, and so we thought at the end of the day, we thought we would be willing to try this RV marginal branch down here, which is, this was definitely not one of our first retrograde approaches. This is an epicardial, and so we had to be prepared. Really, he's a post-CABG heart. It's down low. It's not at the base. I think the ones that are up high at the base actually are quite dangerous. One can have bleeding in areas that were not covered by the pericardial reflection. We've had a case where we had bleeding into the left chest during a perforation so high up. This one would likely to be focal tamponade towards the apex if it were to rupture, but unlikely to cause circumferential tamponade in a post-CABG patient. But we had to be ready both with coils and or thrombin injection and or fat injection. What is your preferred approach for sealing off
I think most recently I and Manas have both, I've done one and Manas done one, both these situations in marginals, we have actually done fat injections.
I'm becoming very, very impressed by that technique, about the speed and the efficacy.
Very quick, and that's the best part about it, because sometimes in the lab you can't figure out to get the coils, delivery. I think fat injection has worked very, very well. We had a diag and when an RV marginal branch, both left to left collaterals, the one was right to right, and we used in both cases fat injections. Works very rapidly.
And maybe you could just, I actually have not injected fat myself. We've done a coil once, but maybe just for me and the audience, maybe describe how you actually do that. And for example, do you dip the fat in contrast? And what microcatheter do you think really works best? Does it matter?
So we use, in one situation it was a Corsair already placed. In the second situation it was actually a fine cross. We injected through a fine cross. It has to be done through a 3 cc syringe. It has to be loaded into the catheter with the introducer, and then use the 3 cc syringe to piggyback it. We did not dip it with contrast, but I think that's a great idea because that would allow some way to localize. But it definitely was helpful in tamponading and closing off and providing a very optimal seal.
And did you have access from the other side already at that time, where you were able to inject from both sides, or just was the retrograde seal enough to calm things down?
So in these situations, for example, if you're going through this RV marginal, I think if it happens very high or in the mid portion, I think you should be able to seal it with one-sided seal in this rare situation. But in most situations, I agree, you would need some sort of strategy to seal it from both sides. But in this one, if you have a seal somewhere in the mid part of this very tortuous segment, a one-sided seal from the RV marginal side would work. I think that's my personal bias, view. But what do you think? I mean, did you guys deliberate on this? How would you approach it if you had a in the middle portion? That's where it's most likely to happen.
Right, exactly. Probably down towards this area here, right around these curvatures, and then potentially around this area as a microcatheter really traverses this curve. So we were prepared for unilateral side because I did not think that we were going to get antegrade and solve this case, although perhaps with that microchannel, maybe we could have gotten lucky and gotten in there. But our goal was really in trying this was to not overly be aggressive and avoid this situation. We knew while this guy was having high-grade symptoms that, these patients are usually stable enough to not have to force the issue. And so our approach was going to be quite delicate with a wire to limit that. But if we got into it, we felt that we could secure him enough because he was post-CABG, and because this would be lower down where there's likely to be pericardial reflection that had adhesed, that we would have a good seal with just focal distal occlusion.
Again, I invite the viewers and the listeners to chime in here. But Farouc, I'm not sure. I'm sure you have other pictures and you guys looked at it, but I'm not really convinced where is this marginal branch connecting back into the distal right or in the middle. So that activity is still quite a dilemma to me. I have not yet figured it out yet.
The RAO is necessary. And that's what we had to take this picture. So you're exactly right. The RAO really demonstrates that it does plug in below the distal cap, and that would allow us to solve this in a standard retrograde fashion, because obviously if it came into the lesion, that becomes much more complicated. Sure.
This is a very, very good view. So, okay, and what is the strategy right now? So what are you thinking? What equipment do you plan to use?
Right. So the first thing that we always confirm in these situations is we understand the patient's ejection fraction, because we are talking about instrumenting him through his lima, the one graft that is actually working, that supplies his entire anterior wall, and that is collateralizing his inferior wall quite substantially. Now, fortunately, he does have ipsilateral collaterals from the right, so even though we're manipulating this contralateral collateral, we would not necessarily suddenly impede all flow to his inferior wall. But it is still possible with manipulation here that we could get into trouble. So we decide first if we think he is stable enough to undergo an intense retrograde procedure. What is our duration? We think about whether or not hemodynamic support is going to be necessary. We image the iliacs at least locally. In high-risk myopathy patients, we routinely get TAVR protocol CTAs to look at the aortoiliacs in case we need to place things either prophylactically or ad hoc. The approach based on the LAO view is going to be to get into the lima. The other thing that we look at, of course, is the curvature of the lima. When it's highly curved, the potential of the kink is much greater. In this situation, this was reasonably straight, and it plugged in quite distally, which was favorable, that we didn't have to kind of deal with a lot of proximal disease going into this actual one retrograde collateral that we were after.
You're left radial, is that correct?
Yes, our usual approach is to be, for the lima, is to be left radial. That's right. And then a French groin access for the antegrade system.
I think we have a comment from one of the listeners about fat embolization from Anthony Speedy, and I think he agrees that a 0.18-inch lumen and a Benson wire to advance the fat to the microcatheter is what they have used, and it's very similar. We've used a 0.14. So, but however, I think people have tried this, so we're getting some feedback on your question.
Okay, that's great. Okay, yeah, that's very helpful. In your case, you found that just hydraulically pushing the fat through was sufficient.
We did hydraulic pushing, but I think the wire idea is also very useful.
That makes a lot of sense. I think the technique about dipping it in contrast really is a way to confirm delivery, and I think that's a good addition to add to the protocols. So now the question is really trying to get into this very kind of difficult entrance here with this wire. So our plan was to use a long Corsair, 150 centimeter Corsair, and usually we start with a run-through workhorse wire to get in to the terminal apex, and then we switched out, and our wire of choice was going to be Xions. We are certainly willing to use multiple Xions to get through this, and sometimes one needs to sacrifice the Xion with a bigger secondary curve to be able to engage the primary one. But once we get going, we certainly try to avoid exchanges because pulling the wires will usually advance that microcatheter. If it advances into a curve, there can be trauma, dissection, or rupture. So ideally, once we do have our most kind of primary Xion wire that we want to do the surfing and wiring with, we try not to switch that out if at all possible. And so what we tried to do here is, after really visualizing this further, we found an angle here that might allow us to get into the proximal zone. And while it was tortuous, it was not exceedingly high grade and high frequency. There wasn't a telephone cord that was very, very tight. There were some zones here, but the caliber seemed potentially approachable. Here was our biggest concern, that right in the entrance getting going, that we might have some difficulty here in this zone here and this zone here. And so we just, our sense was that we needed to probe this and be as gentle as we can, probing it with just a soft, slow technique with no really minimal antegrade activity and just really gentle rotations of the wire. So we'll get into that now here. And again, we're taking lots of setup shots, finally finding an angle that we can look at here in a caudal type view that really allows us to get in to that where we could visualize and start getting going up and over. And so here now is our workhorse wire that we brought down via a Corsair catheter here, and usually we will have a guide liner up as well to help with support in the proximal lima. Also, that sometimes takes away some of the coaxial, or improves the coaxial state, so that we can actually avoid lima entrance dissections, which definitely, when we are looking to try to fill the collaterals, we're often not scanning back up to the guide, we're just focusing on the distal vessel. And if that lima guide catheter is not coaxial, there definitely can be injury. So we've been happy with using...
Especially from the left radial, it tends to not sit in position unless you have a guide liner in.
Yes, so I think that's really, really an important feature to help with this. We have our 8-French guide ready in an antegrade system here. We thought that if we could get retrograde, that this would allow us to resolve the ambiguity. This would really show us where to advance our antegrade system as well safely. That was the hope, and either we solve this retrograde true to true or by reverse cart if things go well. So here now we have our first Xion, and you can see here we got into this proximal zone here, but we're clearly not taking the vessel that we want retroflexed here. So at this point, we're going to redirect. But at least we got into this here with this first Xion and thought that was a reasonable working view. So we brought our Corsair further down into this to try to capture that zone, but not capture too far, and then redirect. And again, kind of multiple views to really see this. We're certainly, to me, this was the hardest part right here, was really trying to understand if that was going to be wireable. So ultimately, through several turns here, we were able to actually navigate this one. And again, it was a lot of gentle rotations, just letting the catheter stay far back and just letting the Xion do the work to traverse these small curves. Yes?
I'm amazed you still have filling, probably from the second branch, from the top branch. You have actually something very useful here. The top branch is really, really helping you.
That is exactly right. It became very difficult to start seeing filling. We were definitely losing that, and so we had to refer to our reference frames quite a bit to make sure that we were not in some kind of unusual exit perforation here. But it did. The vessel kind of straightened out naturally. The curvature was straight, and obviously here, with confirmation, we know we're in the actual vessel. So this was this part here now, because again, we don't want to ever weaponize our Xion wires. We're letting our our Corsair sit far back from this and just letting the soft part really try to manipulate the curve. Ultimately, we were not successful with that, and we agreed to bring the Corsair catheter up further to straighten out this next curve. And now here's the real-time wiring of this final one. You can see here that it's getting stuck going downward. It's not really making this turn up here. We're just working through it. What's that?
I'm saying there is a full loop there, so it's very difficult wiring. So
it is. It's one where it's just a matter of us just trying over and over to see. We thought it was a big enough caliber, and the Xi'an would be flexible enough that if it found it, it might make it past. And so right here in the next few seconds, you're going to see it take a different direction, and then suddenly it makes the upward loop, and you'll see it advance into the next spiral here. So right there, it kind of straightens out a bit, and now the next curve, it catches it. And so that's the first curve right there. And you can see now that the wire is really free into this upward trajectory. We're still getting filling, which is kind of excellent through that second marginal, and you can see here now it basically starts to go. And at that point, we were able to wire much more distally. So that just took a long time for being patient and hoping that this wire would really just find that special curve it needed to find that. And ultimately, this wire does make the entrance into the distal right and into the distal proximal cap. It turns out to be subintimal. This ultimately leads to a reverse cart situation here, and we can see here now that we were able to, the antegrade system really advanced, and it did make me wonder if I could have just solved this whole case antegrade, as you were saying, Subhash, initially with the wire. But that wouldn't be as much fun to present here, but that would have also been sufficient. So good balloon on Corsair contact here. Their spaces are really fairly close here, and ultimately we saw a little bit of the falling off of this Corsair into the actual reverse cart space, and ultimately externalization occurs. I believe this was with the Pilot 200 here, and you can see it entering the guide. At that point now, it becomes our usual approach, RG3, and these final results ultimately are here after a long degree of stenting. Both branches are open. The ipsilateral collateral is now really outcompeted, but both the early takeoff RPDA really stenting ended before that, and the large posterior left ventricular branch were open, and he ultimately did very, very well without any adverse events, and he's been angina-free for the last 2 years. Just extremely grateful. So difficult.
This is an awesome case. This is an awesome case. I'm so impressed. I personally would have shied away from this and gone more with the full blast approach to the antegrade in this particular way. But this is excellent wiring and superb manipulation of the Corsair with multiple Xi'an wires. I think this is an outstanding case and very, very well presented. So thank you for enlightening all of us.
My pleasure. Our heart rate was probably higher than the patient's during the wiring, but we were happy to be able to solve it that way.
This case would have been, we just came back from CRT on protected PCI, and I don't know all the details about the femoral axis, but this is, given the fact you're going through a lima, and that too, fairly with tortuous epicardial collaterals, might have been something you could have considered or would consider support in the future, I guess?
It's a great, I think if there was any sign of myopathy, for sure. If he had been solely dependent, and if he'd been solely dependent on this collateral for the entire inferior wall, then I think we would have had a much lower threshold. Yes, for sure.
Absolutely.
Yeah. I think the whole. I would love maybe that final comment. Maybe you could expand on your experience with Impella-supported CTO PCI. This is obviously not a well-studied space and is kind of emerging. Certainly, as we get used to more and more hemodynamic support and more complex cases. How routinely are you using this for example, for low EF cases?
We are doing protected PCI with Impella, I would say fairly routinely, but I think that we are not using it routinely with CTO cases. And the reason is that at least both Manas's and my bias is a little bit more towards femoral large French axis which makes any kind of support fairly limited. However, I think here you have a situation where you are going through the lima. I understand that this is not the sole vessel right now here feeding the right, but I think it would be a reasonable case given the fact that you have a left common femoral artery available to use support. We are not doing many cases with CTO PCI with support. Again, I encourage any of the viewers and listeners to chime in and suggest if that would be something they're doing, but we are doing a fair number of protected PCI cases overall, but non-CTO.
We have the same experience, and I have the same increasing awareness of the number of myopathy patients that are being now referred to us for consideration of revascularization, mostly for heart failure symptoms and myopathy.
Sure.
And these cases are they're often post-CABG cases. They're very complicated, and it's always difficult to know. I mean, I think prognostically we feel that even if angina is not the presenting symptom, with myopathy and viable myocardium, if there is an open chance to have an open artery, we might offer these patients a better prognosis and maybe even a better heart failure symptom approach. However, the risks are high, and I think, as you mentioned, sometimes we need bifemoral access for these CTOs, and we don't have a way to do that. I think with the OCath catheters coming out that are 7.5 from the wrist in the sheathless systems that you may be using, that we do have more options now to do heavy-duty work from one radial and one femoral. And I am interested in this, I think, as patients are hitting that wall, the real severe myopaths who may not be destination VAD or transplant candidates, that we might be facing this question more and more.
I agree with you. I think this is going to be, we will have to address this, and large French and sheathless guides, large bore 7.5 French is probably the alternative here.
Yeah.
I have for me, radial has to be a little bit more towards the right side, and, left radial manipulation. I think this is another very, very important point of this case, that this was done from the left radial. And so how did you actually position yourself? Did you stand for this? Just for our interest, how did you position? Did you bring the arm across? Did you stand on the left side and change the direction of the screen? Because you need to be very comfortable for this case.
Absolutely. So our approach to this is, it really helps if the patients do not have a very high BMI. We routinely, what we do is we put finger traps on the left hand, and that allows us to, as we bring the arm across, that allows us to secure the arm in position by these finger traps. These are orthopedic types of finger traps that people use for dislocated fingers. One can actually just secure them. They're inexpensive, and we just add them. And it makes left-sided procedures very well. Then we add an extra TUI, so there might be 2 or 3 extensions to allow us to be very comfortable, so that the back operator can have access to the left-sided manifold. And once that's in place, once we have a guideliner in place with a wire as well, we usually have not struggled to fill the lima. As you saw, it was filling quite well during the case, and this person happened to have a normal BMI, and it was not at all a limitation to proceeding this. In some cases, it definitely can be quite difficult with a big BMI and difficult visualization and sub-selection, but our experience is when we have the guideliner in and the left arm across the groin, that we can often make a lot of progress.
Thank you, Farouc. I'm going to make a point. I'm so impressed by this case that I'm going to actually make a point that Manas views this separately as soon as it's done. I know you have one quick case. If you can, because, if you could briefly go over it very, very quickly, maybe just the angiographic parts, because we don't want to keep everybody here longer than needed. So please go ahead.
Okay, sure. Let's do that. This will be kind of to really round out everything we've done between IVUS guided wiring, retrograde approach. This is an antegrade dissection case that ended up occurring spontaneously ad hoc during a non-CTO initial lesion. So I'll go briefly through it. This gentleman's 48 years old, non-STEMI, severe 2-vessel disease, complex LED diagonal, complex diagonal lesion. And you can see here that in the down here, filling late, is this large diagonal branch. There's a moderate mid-LAD lesion, but here is a bifurcation diagonal of a large diagonal branch. Somewhat complicated entry that requires an S-curve nut. Kind of ambiguous exactly where the lumen is filling. So this presented with a non-STEMI TIMI 2 flow. He also has severe right coronary disease. Here's the areocranial view, and it's hard to see in this view, but the actual diagonal branch is coming off here in a way that is really hard to see in this view. We actually only saw it from the caudal view. And here you can see extremely tight. Maybe there's a chance to wiring, but not exactly well defined. It's often hard to do in the apicaudal view. Significant disease here that would also need to be treated. Non-diabetic normally aft decision for PCI if we could get the diagonal. And you can see here yet another view in the cranial view, TIMI2 flow, some left-to-left collaterals forming. So here's our approach. We have a wire down the LAD, and we're trying to use a wire, and I think this was a Xi'an blue that we were trying to get in here. You can see it's starting to buckle and looking like it's getting subintimal. We're wiring now. We're injecting here, which is making me nervous, but we're really dependent on antegrade flow. We put this is actually a radial case as well, 6 French. You can see here the contortion of this catheter, I think, which was an EBU 3.5. We put an extra wire down here to secure it, but we are not making progress kind of getting into this diagonal branch. And so as we are trying to approach this, we're recognizing that we are not going to be able to wire this. Now, at this point, it looks like we're still in the architecture here of the diagonal, but quite subintimal, quite far away from the distal tip. Would you agree there that you can see?
I think, the caudal view would be better, but I think it's very hard to work in a caudal view. It's so foreshortened. So the views are also very limited. This is a very difficult visualization of the lesion itself.
Right, and so this is areocaudal right now, but you see circ down here.
Yeah.
But and it looks like the wire is on top of this vessel.
On top of the vessel.
Architecture. It's still in the architecture, though. It's a little concerning, but it looks like it is moving with the diagonal branch here. And so at this point, we said, I don't think, after trying for another 15 minutes or so with the Xi'an wire as well, and even an XT, we said we're not likely to be able to wire this true to true. Should we consider a reentry approach here? What do you think about that? Is that worth trying at this point, or should we just stop and bring him back and let him heal up?
I think this is an acute case, so I think stopping might not be the easiest thing to do. Second, that you may have to treat the LAD and then jail off access to this branch. So I think that you need to do something now, I would suggest.
Great point. So we felt exactly the same. And what we see here is this is the LAD wire coming in, and this is the circumflex wire to help anchor the guide because we're radial, and you can see this really kind of awkward loop here. So not a lot of support. Fortunately, he wasn't very calcified. And what we've done here is when we, I'll go back to the other view, is we recognized this wire was subintimal. It looked like it was coming off on top of the vessel. And we agreed to basically bring a microcatheter, then exchange out for a Miracle Brothers 12, and bring in a Stingray device to see if we could re-enter from above. Now, because we are dependent on ipsilateral collaterals here, and we're not set up to do microcatheter injection, we don't have an 8 French guide, we did not think that we were going to be able to inject much to see what we were doing. So we tried to make our position understood that we were on top of this vessel, and the goal was going to be sticking below in this view, hoping that the Stingray would be in orientation to allow us to point downward. There's no guarantees for that. And in fact, we did actually have to change our view here, so we're now in a more type cranial view. But we did ultimately feel like we still thought sticking down made sense. And you can see here now that after we do an initial stick with a Stingray wire, we're swapping with a Pilot 200. And the Pilot 200 found its course. You can tell here it's very naturally straight. It's finding different branches. It's so important. This, Pilot 200, I have basically been fooled. It definitely can slide subintimally and look really good. We did have our contralateral roadmap before, and so it did look like it was following this. We take another picture where we see it wiring in a different angle, and it looks like now we're going to actually pull into a branch right here. Again, further confirmation that we're wiring something that is true as opposed to totally false. I think you can't do this enough to feel confident sometimes. And we were also a little hesitant to start injecting contrast to fill left to left because if we were sub, we could really shut down our reentry zone here as soon as contrast got past the Stingray balloon and and so you never know. The Stingray balloon is really out of plane here, but ultimately. This was successful. We ended up with a two-stent approach here. I think we ended up using a T-stent approach just shy of this. We felt the angle was good enough, and this had been quite a complicated case, and we ended up T-stenting right here with reasonable results. and then he came back a couple hours later, or a couple of days later, to fix his right, and he's done well for the last year or so.
You know, your title of this presentation of using CTO techniques in a non-CTO case is probably the most appropriate message that we could, conclude today, because this is unbelievably very complex, and I can imagine all the decision points that you had to go through with your team making the decision to use a re-entry device in a non-CTO situation. So wonderfully done, by the way. Excellent cases. I'm so impressed to see these.
Thank you so much. It was definitely, it's a stressful thing to realize that you're going to have to use CTO technique in the middle of a non-CTO case, because you're often also haven't really consented the patients for the additional potential risk. And in this case, you have to feel good about the visualization, that you understand the anatomy really well from the initial contralateral filling. We did not want to keep knuckling right there. We could have knuckled a little bit more. It looked like when we got the XT in there, I didn't show that, but there was starting to be some bending. We really confirmed we were in the architecture before doing this, and then fortunately, there was still a good target vessel for reentry. So things worked out, and it is really great to have that, because otherwise, I think we probably would have stopped and had a discussion about two-vessel CABG that really wouldn't necessarily offer him a mortality benefit. And it's nice to be able to complete this case with PCI.
And doing it from the right radial is also extremely good. I mean, I think in some of the situations, you could use a wire, or you could even bring this is not as proximal. You could even bring maybe a guide liner to position yourself. But I've seen this myself, that having the guide in a properly seated position is very, very crucial for these cases.
Yes, I think once we get to kind of multiple wires and multiple balloons, I start to get agitated about the guide liner, and that makes me confused.
Agreed.
So
Agreed.
that's why we had not used it for this particular one. But I was very much lamenting not having a guide liner. Yeah, you can see his curvature. I think that was actually an AL guide at the end that finally fit, but really, really poor support. Fortunately, we did not need a lot of push. That was really the blessing in this case. We did that, and also doing a Stingray case, with a guide liner is also really not easy to do.
It's not doable, actually.
6 French, so that's exactly right. So we really would have had to abandon that part.
I see. That's wonderful. Thank you very much. And I just want to invite one more time all the attendees to comment or type in or send us your comments either through audio or to a text chat. This is a wonderful 3 cases presented by Farouc from Mass General. And Farouc, we will, as Manas always does, we send out a Q&A or a feedback survey to our attendees. If there are any questions which are not asked live, we will surely forward this to you. And again, it will be posted on our study website, so on the Progress CTO website, www.progresscto.com. .org. I'm so sorry. Thank you very much. And Farouc, let me ask you one final question regarding this particular case. Have you already completed his RCA and have a follow-up angio of this?
We did. I don't have the images here, but my partner did them 2 days later, and that was a much more straightforward RCA. Good technical result.
And this lesion looks great, I'm guessing.
The right coronary came out. That was never going to be the limiting factor. It was really whether or not the diagonal was going to be solvable for him to become angina-free. Yes.
Perfect. Thank you very much. And we will post this on our website, and I encourage all of you to either send us some text questions, or if you have any questions about Farouc, please send it to us and we'll direct them to him. And I once again thank all the participants and Farouc deeply for taking the time to present these wonderful cases. And I again apologize for Dr. Berlates not being here. He is busy in a microclip case that is going on for many, many hours.
Absolutely, my pleasure to be here, be part of this, and thank you so much for the invitation.
Thank you very much, all. Thank you so much. Bye-bye.
All right, take care. All right, bye-bye.